So welcome to my channel. Today we are going to start our video with diabetes. Now I am starting my new series on the chapter of endocrinology. The chapter of respiratory is completed where I covered asthma, COPD, pneumonia, pneumothorax. So I have covered those topics in the playlist of respiratory. Now I am going to start my video with diabetes. So diabetes is basically type 1 and type 2. Type 1 is present in adolescents and young adults and children, presents in adolescent, young adults and children. But in type 2 diabetes, it increases with the age. Most of the times, type 1 diabetes is presents with acute onset of polyuria, polydipsia, and weight loss. Type 2 is often asymptomatic and there are mild symptoms. It is associated with obesity, cardiovascular diseases, risk factors, dyslipidemia, and increased blood pressure, that is hypertension. Ketosis can be the most important feature of diabetes type 1. It is often present in type 1, and most of the children present with ketosis when they are first presented in the emergency. Urgent referral is required in case of ketosis. In type 2 diabetes, ketosis is less likely, but with dehydration and concurrent severe illness, it can also present in type 2 diabetes. Type 1 diabetes is presented in various ethnicity, whereas type 2 diabetes is common in Aboriginal and Torres, Maori, and Southern Asians. In type 1 diabetes, there is a history of autoimmune diseases. There can be a history of autoimmune diseases. But in type 2, there is no such history in case of type 2 diabetes. So a very important point is that a presentation of hyperglycemia in adolescent and children. So any case of hyperglycemia in adolescent and children is the case of medical emergency, and it should be presumed and treated for type 1 diabetes until it is proven otherwise, until other diagnosis is made. We are going to manage and we are going to deal with the patient according to the type 1 diabetes diagnosis. It is a very important point. So, what is the diagnostic threshold for diabetes? HbA1c when it is 48 millimoles or 6.5% or more, fasting blood sugar 7 or more, pre-diabetes also is that is the impaired blood sugar is 6.1 to 6.9 in cases of adults and 5.6 to 6.9 in child or adolescents. Random threshold is 11.1 and OGTT after 2 hours is 11.1. So random and OGTT, both of them are 11.1. So you have to memorize these thresholds. There are some limitations for HbA1c when we are dealing with the cases of hemolytic anemia, severe kidney impairment, severe liver disease, anemia of chronic disease, regular phlebotomy, recent blood transfusion, first 3 months postpartum, iron deficiency, and hemoglobinopathies. So HbA1c cannot show the true results, and it can show the altered results. So HbA1c has limitations on these diseases. In symptomatic patients, if the patient have symptoms of diabetes, that is obesity or polyuria, polydipsia, and risk factors are also there. So single fasting or random blood sugar above the diagnostic threshold is enough to make the diagnosis. But if the patient is asymptomatic, it has to be single fasting or random is not enough, and it must be further confirmed by some same lab but on separate day. For example, the patient has done the fasting blood sugar and he's asymptomatic, and the fasting blood sugar has a result of raised above the diagnostic threshold. So we are going to again repeat the fasting blood sugar, but on a separate day. If both of the readings are above the diagnostic threshold, we are going to make the diagnosis of diabetes in asymptomatic patients. So, management of first presentation of hyperglycemia. Actually, there are different topics among diabetes that is important. There would be three parts of diabetes on the topic of diabetes. I would be covering different topics of diabetes in these videos. in these parts. So stay tuned with me. Management of first presentation of hyperglycemia. So, if any patient comes to you and he has first time presented with the complaint of hyperglycemia, and it is termed as blood glucose of more than 20 in adults, first of all, we are going to investigate and treat the underlying cause if the patient has any of that. That is, if there is any concurrent stressor like infection or surgery, or medicate, the patient is on medications like glucocorticoids, they can also cause increased blood sugars. So we are going to make sure that these are not the causes, and we are going to treat these underlying causes first. A very important point we have to keep in mind that any unwell patient, any unwell adult, if he presents with hyperglycemia, we are going to manage him as a medical emergency, right? Because he can have hyperosmolar hyperglycemia, or he can have DKA. So you have to keep in mind that. Now, urgent referral in patients of hyperglycemia. When is urgent referral in patients of hyperglycemia is indicated if the patient has signs of ketosis, or strong suspicion of type 1 diabetes, signs of dehydration and vomiting, signs of infection, altered level of consciousness, confusion, delirium. If any of these conditions are present with hyperglycemia, we are going to urgently refer the patient. Insulin treatment is strongly considered when there is severe hyperglycemia, even the patient is asymptomatic. Right? If the patient, even the patient has do not have any symptoms of diabetes, but he has severe hyperglycemia, we are going to give him the insulin treatment. If the patient has ketones present, we would go towards towards diagnosing DKA. And if the patient do not have ketones and have severe hyperglycemia, we are going towards the hyperosmolar hyperglycemia. So, screening for type 2 diabetes in asymptomatic adults is very important. When the patients need screening for type 2 diabetes, and it is very important in Australia. So, if the patient is Aboriginal or tourist over 18 years of age, we are going to screen him annually. And there is a tool for identify the patient who is at risk for diabetes, and we are going to screen him according to that tool. But in Aboriginal and Torres, this tool do not apply because they are already at the risk of type 2 diabetes. So OSRISK tool is for to identify who is at risk for type 2 diabetes, and this tool is used every 3 years in non-indigenous adults over 40 years, and who are pre-diabetics and high risk for diabetes too. They are We have to use OSRISK tool in these patients annually. And the screening is done with fasting, HbA1c, and OGTT. All of these tests can be used for screening purposes. So there is a specific tool for to diagnose or to check the patients who is at risk of developing diabetes and who needs screening. So it does not apply to Aboriginal and Torres people because they are already at a higher risk of developing diabetes. So it is for every 3 years. It is used every 3 years in non-indigenous adults over 40 years of age to check if they need the screening. And the pre-diabetics and high-risk patients for diabetes 2 are screened annually, and the Aboriginal and Torres people over 18 years, these are also screened annually. While managing the diabetes, there are glycemic targets, certain glycemic targets. We have to set the target so that if the patient reach that target, we are going to check the adequacy of our treatment. Either we have to add another therapy, another drug, or either we have to subtract any drug. So in HbA1c, if there is general population, we are going to consider the F53 as a glycemic target. If the patient has short duration, if the patient has recently diagnosed diabetes, or he has a short duration of diabetes, we are going to and he's on lifestyle modification and metformin, the HbA1c target would be 42. If the patient is on anti-hyperglycemics, 48 would be the target. If the patient has insulin, is on insulin, the HbA1c target would be 53. And in the patients of diabetes who have diabetes for a longer duration, 53 is the target for HbA1c. In case of fasting blood sugar, 4 to 8 is the target glycemic target, and in cases of random, less than, glycemic target is to be less than 10. So, what is the management for diabetes? We are going to start with the lifestyle management. So it is a very important point that what is the remission of diabetes? Remission of diabetes is considered when the HbA1c is less than 48, which is sustained over 3 months without need of anti-hyperglycemics. So if the case comes and the patient is on anti-hyperglycemics and he has a sustained HbA1c of less than 48 over 3 months, we are not going to say that the patient has remission of diabetes. He has to be without anti-hyperglycemics to reach that target. And if he reaches the target of 48, less than 48, it is called as the remission of diabetes, but it has to be sustained over 3 months. In diet, the patient is advised to take the low GI index foods. Physical activity and exercise is very important to manage the diabetes. Weight loss of 5 to 10%, the weight loss decreased up to 5 to 10%. It improves the glycemic profile in obese and overweight patients. There is also a metabolic surgery, or which is also called as bariatric surgery. It is considered in patients with type 2 diabetes who have the BMI of 40 kilogram per meter square or more. We are going to take a look at the algorithm for the basic stepwise management for type 2 diabetes. Now we have the patient with type 2 diabetes. First line therapy is lifestyle modification plus metformin. So this is the first line management for type 2 diabetes. Now we are going to consider the HbA1c and set the individual glycemic targets, as I have previously discussed in the video. Now we are going to see if the patient's HbA1c is significantly above their individualized target, that is more than 16 or 1.5% above the target. If yes, then we are going to add second anti-hyperglycemic drug at the time of diagnosis. But if not, and the patient is managed at lifestyle modification and metformin, we are going to still add some cardiovascular and renal safe drugs. The drugs that have cardiovascular and renal benefits in the patients who have atherosclerotic cardiovascular disease risk, heart failure, and CKD, because diabetes can worsen these disorders and these conditions. So we are going to add anti-hyperglycemic drugs. Even if the glycemic control is good at the lifestyle modification and metformin. So, what are these drugs? If the patient has atherosclerotic cardiovascular disease risk, GLP-1 or SGL2, and if the patient has heart failure, SGL2 is the best drug, and is the SGL2 is for heart failure patients with diabetes, and chronic kidney disease, SGL2 is the treatment of choice for the patient with CKD and diabetes. So now we are going to repeat the HbA1c after 3 months, and we are going to see if the targets are achieved. If the targets are achieved, we are going to continue the drugs and monitor the patient for certain diagnosis and check their glycemic control. But if the target is not achieved, we are going to add another anti-hyperglycemic drugs, and the preference would still be the drugs that have cardiovascular, kidney, and heart failure safe drugs. The preference would be that. So if the patients have comorbs like CVD, cardiovascular, chronic kidney disease, heart failure, GLP, and SGL2, we are going to add SGL2 and GLP2 as another drug. Without comorbs, SGL2, DPP inhibitors, GLP, insulin sulfonylureas, or any of these drugs can be given. And acarbose and pioglitazone are very rarely prescribed due to their adverse effects. Now, after 3 months, we are going to again see if the targets are achieved or not. If the targets are not achieved, we are going to add three or more drugs. We are going to give the therapy of three or more drugs. If the target is still not achieved, we are going to seek the specialist advice. So this is it for the part one video. I will be covering the management of diabetes in the part two. So stay tuned with me. I will be covering oral anti-hyperglycemic drugs, and when we are going to administer insulin and what kind of insulin we are going to start. So stay tuned with me for the part two video. If you like my videos, kindly subscribe the channel and share among your colleagues and like the video and comment your feedback. Thank you.